Good morning. I'd like to call the meeting into order for the second day of our June ACIP meeting. Just a little bit revision in the schedule. So now we'll start out with the agency updates, and then we'll revisit smallpox before then moving on to Japanese encephalitis. And so with that, I guess we probably should take a quick roll call. If you don't mind, Dr. Rubin, and we can just go around.
Rubin,
clockwise.
no conflicts?
Reingold, still no conflicts?
Campus Outcalt, no conflicts.
Vasquez, no conflicts.
Bocchini, no conflict.
Camp, no conflicts.
Belongia, conflict for influenza.
Karen, no conflict. Pellegrini, no conflicts.
Harrison, no conflict.
Harriman, no conflicts.
Riley, no conflict.
Romero, no conflict.
Bennett, no conflicts.
Tempe, no conflicts. One other just point of order. Had an email from Dr. Neil Halsey last night, who's been listening in by the web bridge or phone bridge, and his request is everybody make sure you try and keep close to the microphone, because apparently the reception for people far afield is kind of spotty. So if we can just remember to do that, I think that would be appreciated. So without further ado, let me call on Dr. Shuckett for CDC.
Yeah, thanks. The first announcement I want to make is to thank Cindy Weinbaum for serving as an interim executive secretary for the ACIP, and let the audience know that Ray Strickus will be joining us as the interim executive sec for the ACIP following this meeting. We'll be posting a position for permanent executive sec, we hope soon. Secondly, you've probably been hearing a lot about measles this year. The outbreak that was originated in the Disney parks in California is officially over, but we do continue to have imported cases, and the public health folks are doing enormous follow-up of each one of those individually. We do have some early data that there's been a substantial increase in adult MMR use this year so far. So we're kind of gratified that some of the public awareness is increasing. More than half of the cases this year have been in adults who don't necessarily know or have a vaccine history clearly. Since the February meeting, CDC initiated the Sierra Leone trial to introduce a vaccine against Ebola, together with the College of Medicine and Allied Health Sciences in Sierra Leone and other partners. So far, we've enrolled about 7,000 healthcare workers or frontline workers in that trial and vaccinated more than 3,300. We're continuing that in partnership with the Sierra Leoneans. And I think with that, I will turn things back over to you, Dr. Temte.
Thank you. I'm just going to call on Dr. Freihofer here real quickly, because I think pertaining to the measles, she had some information from AMA regarding exemptions. Sorry to put you on the spot.
No, you're not. At the June AMA House of Delegates meeting, the AMA actually voted in new policy that tightened the limitations on vaccine opt-outs, and the House actually voted to support legislation eliminating non-medical exemptions for federally funded educational programs for children, and also voted to support state medical societies in eliminating non-medical exemptions for child care and school attendance in state statutes. And the AMA Council on Science and Public Health and its Council on Judicial and Ethics Affairs did a joint report that sort of laid out the scenarios. The Council on Science report did the scientific background, and the Ethics Committee kind of did their little ethics thing. And it was really amazing testimony how the physicians that were at that meeting were just adamant about the non-medical exemptions being all that should be opted out of. Very different scene than I think what we would have experienced several years ago. So I think this just shows the effect of the measles and and how things have changed. And I think it's a great opportunity now for as immunizers to move with this momentum, because I think the public is now sort of getting a little bird's eye view as to what can really happen when people don't get immunized, or when we have these pockets, and I think they're understanding what herd immunity is. So I was very excited.
Thank you very much. I don't see that Mary Beth Hance is here, so if we can move to Dr. Sergenko, Department of Defense.
Good morning, sir. So just a brief update. As we were talking about electronic health records yesterday, the Department of Defense is working on a new electronic health record, and based on our conversations, I'm hoping our IAIS will be better integrated with the states in their programs, but that's something to look into. We are involved in post-marketing surveillance of the adenovirus vaccine. The study is complete and results should be coming out shortly, but what Colonel Iacovoni was just telling me, it looks amazingly good. Sharp drop in both cases and deaths. As far as flu vaccine for next year, the Department of Defense is going to be partnering with the Office of Personnel and Management to improve vaccine rate uptakes amongst our federal employees on military installations, both by offering more information through the health benefits program and by offering more vaccines on the installations. And we're conducting a Japanese encephalitis vaccine awareness campaign for the Western Pacific areas that are at increased risks to increase uptake of vaccine amongst our beneficiary populations there. And then finally, the Department of Defense is, along with CDC and other partners, involved in the Ebola vaccine trials. The U.S. Army Medical Research Institute of Infectious Diseases was involved in fielding 2 of those vaccines. And that is all from DoD.
Thank you very much. Dr. Jane Kim cannot be here from DVA, or Department of Veterans Affairs, and I'll just read her updates here very quickly. VHA continues to work on several immunization IT projects to improve documentation of immunizations in our electronic medical record. Current efforts are focused on updates that will provide VA clinicians greater detail about a patient's immunization history, including vaccine administration dose, route, anatomic location, lot number, manufacturer, and which vaccine information statement was provided to the patient. VHA released a set of updated national clinical reminders through their clinical decision support tools about 2 pneumococcal vaccines several months ago, and plans to release new clinical reminders about Tdap and TD and Zoster vaccine later this year. Finally, VHA completed its annual seasonal flu vaccine campaign with 1.8 million doses given to veterans. In addition, approximately 10 to 20,000 doses of influenza vaccine were administered to veterans during the 2014-2015 influenza season through a partnership between VHA and Walgreens. And that is the statement from Veteran Affairs. Dr. Sun, FDA.
Good morning. So just a few highlights since the last ACIP meeting. Since that meeting, the FDA has approved a new vaccine, Quadricel, which is a diphtheria, tetanus, acellular pertussis, an IPV vaccine made by Sanofi Pasteur, indicated for children 4 to 6 years of age, as given as a 5th dose of their routine immunization series, or as a 4th or 5th dose of IPV in their routine immunization series. Also, an important time is June 30th, of end of this month. The FDA will be implementing the new pregnancy and lactation rule for prescribers' information, and what that means is essentially all of the previous pregnancy categories will no longer be used, and this is a revision of the way that the labels will look for drugs and biologics, including vaccines. The idea behind it is to better describe the benefit risk when contemplating prescribing information, prescribing drugs or vaccines for use during pregnancy or for women breastfeeding. It also included a new category of reproductive potential for males and females, which we'll discuss considerations that should be for using drugs or vaccines, if there are any effects on reproductive potential. So this rule will be implemented or phased in, but any new applications received on June 30th or after will have to comply with this labeling requirement. Previously licensed products, there will be a phase-in period to revise that label over the next 3 to 5 years. Also, to follow on what Dr. Schuckert had previously said, this, FDA is working closely with the CDC on the study in Sierra Leone, as well with NIH on the study in Liberia on Ebola vaccines. We held a vaccine advisory committee meeting in February, seeking advice from the committee on potential ways to license an Ebola vaccine. And that's it. Thank you.
Thank you very much. Dr. Houston for HRSA.
Good morning. The National Vaccine Injury Compensation Program had a very busy year processing claims in fiscal 2014. A record number of non-autism claims were filed. In the last fiscal year, a total of 633 claims were filed with our program. So far this fiscal year, 496 claims have been filed. So we're on track to surpass the record that was set last fiscal year. To date, there have been 390 adjudications, of which 313 were compensable and 77 were dismissed. Awards to petitioners have totaled approximately $169 million to date, and attorneys' fees have totaled approximately $14 million. More data about the program can be obtained at our website, www.hrsa.gov/vaccinecompensation/data. The program has been developing regulations to make changes to the vaccine injury table. First, a notice of proposed rulemaking to propose several changes to the table has developed and is being reviewed by the Department of Health and Human Services. The final rule, adding intussusception as an injury for the rotavirus vaccine, was published on June 23rd, so just this week. A Public Readiness and Emergency Preparedness Act declaration covering certain Ebola vaccines was signed on December 3rd, 2014, and became effective December 27th. A few therapeutics were also added to that declaration. So people who have received the covered countermeasures are eligible to file a claim with the Countermeasures Injury Compensation Program. The CICP and the VICP continue to work on outreach efforts to let the public and providers be aware of these safety net programs. Thank you.
Thank you very much. Indian Health Service and Ms. Groom.
Good morning. Thank you. Just a few updates from the Indian Health Service. Our EHR currently has reminders for all of the routinely age-based recommendations. We just added the PCV13 for those 65 and older, rolled that one out across our system. And we're also exploring looking at more clinical decision support for those high-risk conditions. We have hepatitis B for diabetics in our system, and we're currently working on ones for pregnant women and people with chronic liver disease. In terms of performance measures, we've changed our flu measure. We've been monitoring flu coverage among adults 65 and older for many years, but we felt that it was really high time that we changed that, so we now have changed our performance measures for the agency to align with Healthy People 2020, and we'll be looking at flu vaccine coverage across our population. And we're also exploring a developmental measure to look at Tdap and flu among pregnant women that we hope will also inform our reminder, and continuing our work around a composite adult immunization measure to look at coverage at all of the age-based recommendations for adults. And then finally, in terms of influenza, we remain pretty frustrated at our fairly stagnant coverage levels, and so that's some initiative that our Chief Medical Officer has really asked us to focus on. So we've developed a pretty aggressive influenza action plan, and we're really asking our different regions to take that to heart and come up with a plan to get us to that Healthy People 2020 goal. So hopefully we'll have more information to report on that as that rolls out.
Thank you. Dr. Gorman for NIH.
Good morning, and thank you. I'd like to start off with some words from Dr. Collins, who is the head of NIH, about his precision medicine initiative. Far too many diseases do not have a proven method of prevention or effective treatments. We must gain better insights into the biology of these diseases to make a difference for the millions of Americans who suffer from them. Precision medicine is an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyles for each person. While significant advances in precision medicine have been made for select cancers, the practice is not currently in use for most diseases. Many efforts are underway to make precision medicine the norm rather than the exception. And to accelerate this pace, President Obama has now unveiled the Precision Medicine Initiative, a bold new enterprise to revolutionize medicine and generate the scientific evidence to move the concept of precision medicine into everyday clinical practice. NIAID and NIH are also involved in the Ebola vaccine trials in Liberia, a large clinical trial to assess the safety and efficacy of 2 experimental vaccines to prevent Ebola virus infection is now still open to volunteers in Liberia. The trial is being led by a recently formed Liberia-U.S. Clinical Research Partnership and is sponsored by the National Institute of Allergy and Infectious Disease. The study is called the Partnership for Research on Ebola Vaccines in Liberia, or the PREVAIL study, a phase 2-3 study which was originally designed to enroll approximately 27,000 healthy men and women aged 18 and older. There are at least 3 vaccine candidates presently being tested by all players. One is the NIAID GSK chimp AD3, the new link Merck RSV VSV Ebola virus, and the Janssen Bavarian Nordic AdVac Ebola MVA are the 3 candidates. In terms of therapeutics for Ebola, there are 6 major therapeutic candidates. ZMapp, an antibody cocktail that binds and inactivates the Ebola virus. TKM Ebola, a small interfering RNA. BCX4430, a nucleoside analog RNA polymerase inhibitor. Encyclovir, a small molecule viral polymerase inhibitor with apparent broad antiviral properties. And favipiravir, which is licensed in Japan for pandemic influenza post-exposure in mice. Post-exposure efficacy in mice has been shown towards Ebola. An adaptive clinical trial has been constructed for the evaluation of the therapeutic candidates of Ebola for Ebola disease. This design was constructed by the government of Liberia, the University of Nebraska, and the Emory University. This trial will compare enhanced standard of care to enhanced standard of care plus a therapeutic candidate. ZMapp is the first candidate. Other agents will be tested based on the supportive data and availability of the product. The very heartening decrease in the number of new cases of Ebola makes completions of all these trials much more difficult. Moving on, there's a supplement. There's an inclusion of pregnant women in clinical trials of antimicrobial diseases and vaccines, which is a supplement to clinical infectious diseases. It has 6 articles in it in this supplement. Many of the authors sit either sit now or sit before on the inner circle or the outer circle of this particular group at ACIP. On the NIAID website, there's a slideshow that highlights the notable scientific advances made by NIAID laboratories and NIAID-funded researchers at domestic and international institutions during the fiscal year of 2014. Some advances have brought us closer to the much-needed vaccines and treatment for Ebola, HIV, and influenza. Others have expanded our knowledge of rare conditions such as prion disease and immunodeficiency disorder. All are representative of how public investment in biomedical research can advance science and benefit human health. And lastly, down in the weeds a little bit, DMID clinical trials for vaccine candidates that are ongoing. We have a hepatitis C vaccine trial ongoing, an influenza H7N9, several, and a Zostavax for transplant patients that is also ongoing. And in development, there is a West Nile vaccine trial that the phase 1 has already been awarded to the Duke VTU site, and we are in the IND enabling studies that are to allow a phase 1 testing of a universal flu vaccine candidate. Thank you.
Thank you very much. Dr. Ornstein for NVAC.
Thank you. The NVAC met on June 9th and 10th and finalized 3 reports which should be available on the MVPO website in the near future. First deals with vaccine confidence. Vaccine confidence was defined as the trust that parents or healthcare providers have in the immunizations recommended by the ACIP, the providers who administer vaccines, and the processes that lead to vaccine licensure and the recommended vaccination schedule. There are 5 categories of recommendations, including better measurement and assessment and tracking of parental attitudes towards vaccines, development of effective communication and strategies to build vaccine confidence, issues of healthcare provider strategies, including development of materials for them to deal with parental concerns, a focus on curriculum for both continuing medical education as well as physicians in training on vaccination issues, and development of a working group to look at compensation issues for vaccine counseling. Other strategies included tightening of exemption policies and monitoring and support. The second report dealt with HPV vaccination, where the NVAC endorsed the President's Cancer Panel report, which is a comprehensive set of recommendations to improve HPV vaccine uptake, and added a few other things in it, including building of communication strategies, strengthening immunization systems and adolescent immunization in registries, as well as other things, and then a review of the schedule as to whether the HPV vaccine schedule be simplified to enhance better compliance. The third role is actually, in part, what Rich was talking about, is the role of vaccines in antimicrobial resistance. The NVAC made a strong case to consider vaccines in efforts to combat antimicrobial resistant bacteria, including having a liaison on the NVAC from the President's national strategy and combating antimicrobial resistant bacteria on the NVAC itself.
Thank you. And then Dr. Gillen.
So Walt failed to mention is there's now a standard clause at the end of every set of NVAC recommendations that says, and the National Vaccine Program Office will figure out how to do all this stuff. So that's so there's that part that goes with each of those. In addition, I think that the few things I wanted to highlight is, I've mentioned this before, but the National Adult Immunization Plan is in final clearance. And among the things, and I think it reflects the conversation we had yesterday about registries and Ann's comment about it was hard to know which adults had actually had vaccines, about a focus on health IT and the importance of registries to keep the information flow. Also, a month ago in Atlanta was the National Adult and Influenza Summit, which is something that is organized by CDC, Immunization Action Coalition, and NVPO. And some of the themes there were the implementation of NVAC standards of adult immunization practices and a focus on the last mile with really a look at implementation science. People sort of know what they're supposed to be doing, but how do they do it? How does that work? And I think that was an important theme. There's a few other things from the National Vaccine Program Office. There's an interagency vaccine safety task force that is really a cross-government, not just HHS, and VA and DOD, that has put together a vaccine safety scientific agenda that's on the NVPO website. I encourage you to take a look at that. We're about to release a year in review, which from last year, which is sort of a magazine-style highlight of many things that happened, both the vaccine and immunization front last year. And Judy Mendel from our staff did a nice job putting that together, and we'll get that in your inboxes. And then finally, we're going to talk about HPV today. And on that front, the Office of Women's Health, the Office of Adolescent Health, and National Vaccine Program Office have put together a WebMD program that I guess will start at the end of June, the consumer parent information.
Thank you, Bruce. And if I can ask Dr. Peterson to come on up, this is just the recap.
Can I make just one comment on non-medical exemptions? The University of North Carolina hospitals had a policy for many years to accept only medical contraindications to vaccines, and we require as a condition of employment all the ACIP recommended vaccines for healthcare personnel. We had 2 complaints filed with the EEOC, one on Tdap and one on MMWR, MMR. So, in both cases, the EEOC ruled that if we accept medical contraindications, we must accept religious objections. And so, despite our policy being approved by the State Attorney General in North Carolina, it was overruled by the EEOC, and we can no longer accept only medical indication.
Thank you. Also, Ms. Hans, if you can give the CMS update, and then we'll move into Dr. Peterson's presentation.
Sure, I apologize. I have one minor update, and that is as a result of the measles outbreak, I had a call with all of our state Medicaid directors in March and helped with that call and participated in it to remind Medicaid directors the importance of high-level vaccination coverage and working with providers to ensure that all Medicaid recipients and all children maintain vaccination. We're also working to try and improve our Medicaid data and make sure that we have a real handle on what the Medicaid
and thank you. So, Dr. Peterson, we'll turn it over to you.
Great. Thank you. Good morning. So following the discussions yesterday, we put together a number of proposed revisions which we hope will address the major concerns that were raised. The first was a request to change the worker to personnel in the policy note, and we feel this is more than appropriate in an effort to be more inclusive, so we will make that change. The second is based on a request to provide a little bit more specificity in the healthcare personnel that are addressed in the policy note, and so we've added a little bit more language that further qualifies the healthcare personnel as those that currently treat or anticipate treating patients with vaccinia virus infections. The next was a question regarding the responder population that may have already been vaccinated during the 2002 smallpox vaccine program. And this policy note does not specifically address that population. However, there is already CDC guidance regarding revaccination of this population. And so we felt it would be reasonable to include a reference to that guidance. And lastly, there was a question about the post-exposure management of persons who were exposed to orthopox virus. And the working group did briefly discuss this issue, but didn't feel that there was really enough data to provide a strong recommendation for the possibility of post-exposure vaccination in persons who have been exposed to an orthopox virus. So we propose including a statement that persons with an orthopox virus exposure should be evaluated by a healthcare provider, and clinical management decisions, including post-exposure smallpox vaccination, should be made on a case-by-case basis in consultation with public health authorities. So those were the revisions that we put together. I'm happy to take any further questions, further discussion.
We'll open it up for any discussion. Is it possible to put the language of the recommendation up there? Thank you. Dr. Weber, does this address some of your concerns?
Yes.
Okay. And around the table, do you feel that this addresses the concerns we had yesterday? We're a very compliant group this morning. Do I have a motion for acceptance? Dr. Riley? Do I have a second? Dr. Romero? Any further discussion? And seeing none, Ms. Pellegrini, if you could start us off, and we will go to your left.
Pellegrini, yes.
Harrison, yes.
Harriman, yes. Riley, yes.
Middle, yes.
Bennett, yes.
Empty, yes.
Rubin, yes.
Reingold, yes.
Campus Alcohol, yes.
Vasquez, yes.
Okini, yes.
Camp, yes.
Belongia, yes.
Aaron, yes.
And the motion passes 15-0. Thank you. This was very painless, and we appreciate your efforts overnight to update and revise.
My pleasure.
That being said, we can move along now to the Japanese encephalitis and Dr. Bocchini.
Good morning. I first want to thank Dr. Tempte for his leadership and thank everyone for the opportunity to serve on the ACIP these past 4 years and to work with this group of experts. It's been a really wonderful experience for me, so thank you. The Japanese encephalitis and yellow fever work group is just providing a information session just to let you know where we are at the present time with work on updating the information for Japanese encephalitis vaccine use. Just as background information, an activated viral cell culture-derived JE vaccine, which is JEVC, IXIARO, is the only JE vaccine currently available in the United States. The inactivated mouse brain-derived vaccine, JEMB, is no longer available. JEVC is manufactured by Valneva, formerly Intercell, and is distributed in the United States by Novartis. ACIP recommendations for the use of JEVC have evolved as follows. In 2009, the FDA licensed the JEVC for adults, and at that point, ACIP approved recommendations for primary series use in adults, and in 2010 published an updated MMWR recommendation and report. This was the first modification since 1993. In 2011, ACIP approved recommendations for use of a booster dose in adults based on new information and published that policy note in MMWR. And in 2013, ACIP approved recommendations for use of a primary series of JEVC in children and published an additional policy report in MMWR. Once we completed the work with yellow fever vaccine, the work group was tasked with updating the recommendations and guidance for use of JE vaccine. So this includes a review of newly available safety and immunogenicity data, a review of the epidemiology and risk of JE in travelers, and a review of the current ACIP recommendations for use of vaccine in consideration of updated safety, immunogenicity, and travel data, with potentially recommendations coming to ACIP for possible changes in guidance. And then lastly, to update the 2010 recommendation and report, including all of the additional information. So we already know that the update will need to remove JEMB vaccine from the information and recommendations, and add the booster dose for adults and the primary series recommendations for children. In addition, this slide shows the data that is currently available that the work group needs to review on JEVC vaccine. There's considerable post-licensure safety data. There is data on use of a single primary dose for people who previously received JEMB. And there's data on increased and decreased intervals between the two primary series doses, which are typically given 28 days apart. There's additional data on co-administration with rabies and meningococcal vaccines, and data on duration of protection and additional booster dose recommendations. It's also expected that within the next few months, at least before the end of 2015, the Department of Defense will have data from a post-licensure safety study. In addition, the manufacturer has requested a meeting with FDA to discuss acceptability of data for alternate dosing schedules, co-administration, and booster dose indications, and they might submit a proposed label change related to these data in 2016. So our plans are to continue our meetings by teleconference so that we can complete our work to present a revised MMWR recommendation and report to ACIP either in October or in February 2016. Timeline will be dependent upon availability of data, and if complete our work, it is very possible subsequent to FDA decisions based on manufacturer submission of data, additional ACIP votes and policy notes may be needed in 2016 and 17 as new indications are approved by FDA. I want to thank the members of the work group. This has been a work group that has considerable expertise in travel medicine and in the use of both of these vaccines and the diseases they prevent. I want to especially thank Fisher, Susan Hills, and Aaron Staples, who have been very important in making this work group work. So thank you.
Thank you much, Joe. Any questions or comments? Okay, thank you so much. And I guess we can move along to the pneumococcal presentation and Dr. Bennett.
Good morning. Before I start the presentation for pneumococcal vaccines, I too wanted to thank Dr. Tempte for his great leadership. Needless to say, in the pneumococcal realm, we've been very busy in the last couple of years, and we've really appreciated all your support. So today, I first wanted to thank our work group. The work group has been busy, although a little less busy than we were probably a year ago. And I particularly wanted to thank Tamara Pilishvili, who is our fearless leader and who has really done a great job. As you know, the terms of reference for the pneumococcal work group have been to continually review current data and revise or update recommendations as indicated by the data. Most recently, we approved the adult dose of PCV13, and we presented a variety of recommendations about how this dose be given. The focus of today's session is to try to harmonize the intervals between PCV13 and PPSV23. There's been many, many questions about these intervals, and when we originally recommended them, we had taken into consideration a number of factors. However, there were relatively few data available to help us make those decisions about the intervals. So today we are going to talk about those intervals and suggest ways of harmonizing them and actually ask for a vote. The recommendations for PCV13 and PPSV currently are outlined on this slide. We basically recommend it for adults 65 and over and for individuals 2 to 64 with immunocompromising conditions, functional or anatomical asplenia, and CSF leaks or cochlear implants. The sequence is the same across all recommendations, which is PCV13 followed by PPSV23. However, if PPSV23 has already been given, we also recommend that PCV13 also be given. And the intervals have been decided by age group because of the sequence in which we made these recommendations. This table just outlines the current intervals and the groups for whom this vaccine is recommended. As you can see, the biggest differentiator is the intervals for those over the age of 65. So today we'll first talk about the rationale and evidence for the proposed changes, and Miwako Kobayashi will present that to us. And then Tamara Pilishvili will talk about what the proposed changes are specifically, and if agreed upon, we will have an ACIP vote. So with that, I would like to ask Dr. Kobayashi to present.
Thank you very much, Dr. Bennett. Good morning. Currently in the United States, there are 2 types of pneumococcal vaccines that are being used. The 13-valent pneumococcal conjugate vaccine, or PCV13, and the 23-valent pneumococcal polysaccharide vaccine, or PPSV23. For individuals with underlying conditions 2 years or older, and for all adults 65 years and older, administration of both vaccines in series is recommended to maximize protection against pneumococcal disease. The 2 vaccines are recommended. PCV13 should be given first, followed by PPSV23 whenever possible, as studies have demonstrated that immune response was greater when PCV was given first. When PPSV23 is given first, there is a recommended interval wait before administering PCV13. However, under current ACIP recommendations, recommended intervals between PCV13 and PPSV23 are not consistent across age and risk groups, and also depend on the sequence the two vaccines are given in. This is a summary table showing the currently recommended intervals for the sequence of PCV13 followed by PPSV23 and PPSV23 followed by PCV13 for different age groups. As Dr. Bennett outlined, the recommended intervals are different by age groups, risk groups, and the sequence in which the vaccines are given. Given the complexity of recommendations and following many suggestions received by the Pneumococcal Workgroup to harmonize recommendations across different age and risk groups, the workgroup considered the following question: would existing data allow harmonization of intervals between PCV13 followed by PPSV23 and PPSV23 followed by PCV13 across age and risk groups? In the following presentation, I will first review the sequence of PCV13 followed by PPSV23, which is the preferred and recommended sequence the two vaccines should be given in. Then, I will review the sequence of PPSV23 followed by PCV13. In each of these sections, I will go over the current recommendations, considerations for harmonization of intervals including review of available evidence, and lastly, introduce the proposed changes to existing recommendations for intervals for ACIP vote. First, we will review the intervals for the sequence of PCV13 followed by PPSV23. This table summarizes the intervals that are currently recommended for different groups. There are potentially two ways to harmonize these recommendations: either by changing the interval recommended for children and adults with underlying medical conditions, or changing the interval recommended for routine administration for adults 65 years and older. Since individuals with underlying conditions listed here are at higher risk of getting invasive pneumococcal disease, the workgroup did not think that the recommended interval for these age groups should be prolonged from the current 8 weeks. Therefore, we considered changing the interval recommended for routine administration in adults 65 years and older to be consistent with interval recommended for those with underlying conditions. However, review of existing literature did not support that change, as we will discuss later. Therefore, harmonizing the interval within the same age group, that is, the interval recommended for the sequence of PPSV23 followed by PCV13 for adults 65 years and older, was considered. We considered several factors when determining whether the change in interval is warranted. First is related to implementation and programmatic challenges. As we saw earlier, the current interval recommendation for PCV13 followed by PPSV23 for routine administration in adults 65 years and older is different from that of PPSV23 followed by PCV13. Different intervals have caused confusion among healthcare providers administering the vaccine. It also creates challenges in programming vaccine reminders in computer-based programs or used as a quality measure. And lastly, Medicare currently covers a different second pneumococcal vaccine 1 year after the first vaccine was administered. This suggests that Medicare beneficiaries who receive PPSV23 within a year of receipt of PCV13 would not be covered. We then reviewed existing literature to see if evidence would support changing the interval for the sequence of PCV13 followed by PPSV23 to 1 year or longer in adults 65 years and older. To answer this question, ideally, we would like to review clinical efficacy studies designed to directly compare different intervals for the sequence of PCV13 followed by PPSV23. However, only limited data from immunogenicity studies are available, and only one study included a direct comparison of intervals. The rest of the studies compared the immune response after the sequence of PCV, either 7-valent or 13-valent, followed by PPSV23, to the response after a single dose of either PCV or PPSV23 using various intervals. We compare these results from different studies to assess whether there's an association between the interval in PCV followed by PPSV23 series and immune response. This slide summarizes the results from studies in older adults that provided data on comparison between the immune response after PCV followed by PPSV23 sequence to the immune response after a single PCV dose. In this comparison, we are interested in whether the immune response after sequential administration would result in responses that are as good as or greater than the response after a single dose of PCV. Of note, the two studies referenced for the 1-year and 3 to 4-year intervals were designed to assess non-inferiority of immune response following the sequence compared to a single dose, whereas the rest of the studies referenced in this presentation assessed whether the differences between the groups compared were statistically significant. While it is difficult to compare the results across different studies, immune response following the sequence appears to improve with increased interval between the two doses. This slide summarizes results from studies in older adults that provided data on comparison between the sequence of PCV followed by PPSV23 to the immune response after a single PPSV23 dose to assess whether adding PCV before PPSV23 would result in an improved immune response with the interval used in each study. Here also, we observe a tendency for studies using longer intervals to result in improved immune response, although again, direct comparison across different studies are difficult to make. One study with direct comparison between different intervals was done among Alaska Native adults ages 55 through 70 years. The results were also included in the previous slide. Participants were randomly assigned to 3 groups, which either received PPSV23 only, received the sequence of PCV7 followed by PPSV23 2 months apart, or the same sequence 6 months apart. Immune response was measured by IgG concentrations and opsonophagocytic assay for 5 pneumococcal polysaccharides. The results showed that the immune responses measured 2 months after the receipt of PPSV23 did not differ among the 3 study groups for any of the 5 pneumococcal serotypes measured. Of note, more injection site swelling that was statistically significant was noted in the group with 2-month interval compared to the group with a 6-month interval. In summary, none of the reviewed studies were designed to identify the optimal length of the interval between PCV13 and PPSV23. In addition, comparisons across studies are difficult to make given the differences in design and target population. The intervals used in the studies we reviewed range from 2 months to 3 to 4 years. Comparisons of a response following a PCV followed by PPSV23 series versus a single dose across studies utilizing these intervals showed that longer intervals, such as a year or longer, may result in improved immune response compared to shorter intervals, such as 2 months or 6 months, in older adults. Of note, the one study that conducted direct comparison between 2 months and 6 months showed that shorter intervals was associated with increased reactogenicity that was statistically significant. Lastly, we will need to consider the possibility of increased risk window for pneumococcal disease caused by serotypes contained only in PPSV23 and not in PCV13 by prolonging the recommended interval. This figure summarizes the incidence rate of invasive pneumococcal disease, or IPD, by serotype in age group from the 2013 active bacterial core surveillance data. These data are observed in a setting of PPSV23 coverage of approximately 60% among adults 65 years and older, but before routine use of PCV13 in this age group. The blue portion of the bar represents the proportion of invasive pneumococcal disease caused by serotypes contained only in PPSV23 and not in PCV13, and is approximately 40% across all age groups. The overall burden of disease, as well as incidence of IPD, caused by PPSV23 only serotypes is higher in older groups. However, the potential change in the recommended interval will mostly impact those who are younger, that is, those who are turning 65, as they are the ones who are most likely to be naive to PPSV23 and therefore more likely to receive PCV13 before PPSV23 and be affected by the change in the recommended interval. In conclusion, we consider that changing the interval between PCV13 followed by PPSV23 from the current 6 to 12 months to at least 1 year or older for adults 65 years and older would be appropriate for the following reasons. First, the change will allow us to harmonize the recommendation with the interval for the sequence of PPSV23 followed by PCV13 for the same age group. Second, this will be consistent with the current CMS policy. And lastly, immunogenicity studies suggest that an interval of a year or longer between PCV13 and PPSV23 is appropriate and may lead to a better immune response compared to the one achieved with shorter intervals in older adults. The change in the recommended interval may result in up to 6 months increase in risk window for invasive pneumococcal disease caused by serotypes only contained in PPSV23. However, 1 year is still within the current recommended interval, and this change is likely to affect mostly the younger age group naive to PPSV23 and whose overall risk of pneumococcal disease is lower within the age group of 65 years and older. Therefore, we propose to change the interval between PCV13 followed by PPSV23 from the current 6 to 12 months to at least 1 year. I would like to pause here and would like to take any clarifying questions related to the content of just what I just presented, and then afterwards we will move on to the other sequence.
Thank you. I have just one quick practical question. And since we've had PCV13 recommendation for now 10 months, do we have any idea how many people over the age of 65 have received the PCV13 and then PPSV23 6 months later? As far as I'm aware, it doesn't happen in our practices because we don't commit our seniors to that financial burden. So I'm just curious whether or not that really happens at this point.
Unfortunately, we do not have that information at hand.
Ms. Groom.
Just a quick comment on that. We don't have the data on coverage yet, but I will say that we programmed our reminder to give the PPSV23 at 6 months because we felt very urgently that the burden of disease in our population was high enough that we wanted to get that dose in as quickly as possible. And looking at that data, I just remain concerned that it seems like a CMS policy issue is what's maybe driving a change to 12 months rather than 6 months.
Dr. Harrison.
I share that concern, and also you keep saying may be better, and can you go back and show us the data that it is better, because it didn't seem overly overwhelming.
Right. So unfortunately, we have limited data regarding. Sorry, Dr. Shuckett, were you raising your hand? Okay. There are no clinical efficacy data comparing the intervals directly, so we are basing our recommendations based on what we have, which are immunogenicity studies. And again, these studies are using certain intervals, and then we are comparing these different studies using different intervals. So these are summary of studies using the sequence of PCV followed by PPSV23 using different intervals compared to their immune response after a single dose of PPSV23. And again, two of these actually, the 2-month interval and the 6-month interval, was done in the same study. They compared the immune response after PPSV23 only, after 2 months in between the intervals, and then between 6 months between the intervals. For that study, it did not show any statistically significant difference between the response. But if we look at studies that use longer intervals, such as 1 year, there is some data showing that there is a greater response compared to after a single dose of PPSV23.
So can you point out exactly what's leading to that statement? Is it the 6/7 versus 4/9, or?
So this is the result of the study that used a 1-year interval between PCV followed by PPSV23. And that immunogenicity study results show that 1 out of the 7 serotypes measured had equivalent result comparing after the sequential dose versus the response after single PPSV23 dose. And then 6 out of the 7 serotypes had a greater response after the sequential administration compared to a single PPSV23 administration.
Are the GMTs, do you have any data? Can you show us the GMTs?
I may not have included that slide.
But in the meantime, this whole CMS question, I'm just curious as to why CMS wouldn't allow for payment according to ACIP guidelines.
Dr. Schuchat.
I think just a couple comments, and Dr. Moore also wanted to make a few comments. The vast majority of pneumococcal vaccines in adults are given out in the fall. The incidence of pneumococcal disease in seniors is not flat in the year, so a 6-month period is the incidence or risk of disease in a 6-month period could be quite different depending when the 6th month is. So I think this urgency about missing 6 months of coverage is not necessarily a big deal. The issue of GMTs, they're not necessarily correlated with protection, so there's a lot of grayness to how to interpret the GMTs. And then I think Dr. Moore wanted to speak a bit to the CMS issue really being a red herring here.
Yeah, thanks, Dr. Schuchat. I think the question of what's driving this is really around provider confusion. The number one question we've been getting since this recommendation, since this extraordinary meeting last August, was what is going on with these intervals? Why is it one way for this group and another way for that group? Just yesterday, I got an email from a provider who's in charge of programming their electronic medical records and their decision support for pneumococcal vaccines, asking whether ACIP was going to take up this very issue. So it was easy for me to say, well, tune in tomorrow because we'll be discussing it then. The CMS issue it's not driving this. It's all about making it easier for providers to stick to the recommendations.
And I'd like to just reinforce Dr. Schuchat's comment that go on the influenza website and look at the pneumonia and influenza death index, and it is remarkable the incredible seasonality of pneumonia deaths in this country, and it's really confined over about a 4-month period every winter. So, Dr. Schuchat.
I think I might have not made my point very clearly, but there is an enormous amount of public and private health promotion every fall to promote both influenza and pneumococcal vaccines, and it would be much easier to take advantage of that in terms of trying to implement recommendations for first or follow-up vaccination. That is sort of a good bus to be on for this, and it's also timed to protect people before the intense season of pneumonia and influenza. So a 6-month thing is just not as practical from that point of view as a 1-year thing.
I have Dr. Lett, Dr. Campos-Outcult, and Dr. Baker, and Dr. Harrison.
So thank you, and I'm really glad that I'm one of the people that works on all of the clinical decision support in our registry, and so I'm really glad that you're addressing that. The one question that I had, and you're maybe going to get to it later, is, and to clarify now, if we're changing these intervals, like for us, it's really black and white in terms of marking doses as valid or not valid, and we've programmed our registry then to not recommend another dose if the interval is too short based on our consultation with your group. And so I just wanted to get some follow-up about if for some reason, someone has an interval that's too short between these doses, that we're not repeating the dose. And maybe you were going to get to that later, but I wanted to clarify that. Is that true? Yes, thank you.
Thank you. Dr. Campos-Ocol.
So question on this slide. How many serotypes were measured? And why, I mean, were you measuring the 23 in PPSV? Were these studies doing that? Or were they measuring the 13 in PCV or the 7 in PCV?
So the results here have...
9 and 7.
I'm sorry.
So, but not, is that the 9 serotypes were from the PCV vaccine that they measured?
Yes. So so for this study, it's from the McIntyre study, and then they basically, so they measured the serotypes that were common between. So this was the study that used PCV 7. Mm-hmm. So the results here have a mixture of the studies that used PCV 7 and PCV 13. So that's why the PCV type was not specified. So the serotypes they measured are, usually the common serotypes between PCV and PPSV 23. Sometimes they only chose like a few serotypes that were common based on various reasons. So the denominator is basically all the number of serotypes that they measured, which were common between the two. Sometimes they have included 6A.
Yeah. Okay, and then second question. I'm having a hard time reconciling the decision not to change the interval for the high-risk groups with this decision to change the interval here. I'm not sure I'm understanding the reasoning behind that.
So I guess your question is why we're not making the intervals shorter for the older adult groups.
Or longer for the high risk.
Oh, longer for the higher.
Either way.
So I might have not clarified, but this is only from studies that were done in older adults. So for higher risk adults, higher risk population, there are studies that are done, but then if I recall correctly, they were using shorter intervals. So basically there's no good evidence to support making the intervals longer. So the problem we're facing here is basically lack of good data to support an optimal interval.
Go ahead, Dr. Bennett.
I think another consideration is that the majority, actually, of the over 65 group is relatively healthy, whereas the people that we're recommending this vaccine for in the younger groups are at high risk.
I'm going to move on to Dr. Baker, and just we have Dr. Harrison, Dr. Whitley-Williams, and Dr. Paradiso.
So speaking as a pediatrician, there's really good data for the 8-week interval in children at high risk. And we don't have data has been very clear. So I'm now speaking for the IDSA. There was robust interest among the public health people. The chair of the Public Health Committee of the IDSA is Jeff Dushin. You may remember him. And one of the work group members is also a member of the Public Health Committee. So the IDSA position on this is to go with this, and even though it's not perfectly simple, I think the data show that an 8-week interval, we don't have great data, but I think if we had more data, it would show that it's too soon. And from a practical point of view, being in the age group, people go to the doctor once a year if they're healthy. So, it's when they go, when CMS is going to pay for it. One of my colleagues at an antidote went at 6 months and found out she's healthy and, found out she'd have to pay out of pocket and said, I'll be back. So I think this is the IDSA position is it's not perfect, but they're very supportive of what you see on the slide that was there before the one you went back to. And then a question. So one of our problems is there's not a lot of data. Are we going to have more data?
Unfortunately, I don't have the answer to whether there are better data coming to have a better basis for making recommendations. Dr. Shuckett?
Yeah, I was just going to say that the program is planning to do post-licensure vaccine effectiveness in adults. So I think that rather, as I mentioned before, the antibody levels are very difficult to interpret, and I think the reality is that there's a lot of vaccination going on at a variety of intervals and sequences, and there'll be, in the next few years, more data forthcoming. So I would say that's the data to look for.
Thank you. Dr. Harrison.
I was just wondering if any flexibility will be written into the recommendation in terms of if somebody comes in at 6 months and wants to be immunized, and will the language allow for that?
Okay. Thank you for your comment. I think maybe we can address that when we come to the actual language that we propose for the vote, and maybe we can discuss that at that time.
We have Dr. Whitley Williams.
Thank you, Pat Whitley Williams from the National Medical Association. You quoted that the coverage rates were 60% overall, but I would like to acknowledge that the coverage rates in Black Americans and Hispanics are more around 45, 46%. And although it doesn't directly address the issue of the intervals, if we can't get people in to get their first pneumococcal immunization above 65, at 65 or above 65 years of age, the question is how much difference will this make on the burden of disease, particularly in those high-risk populations. Also, these underrepresented minority populations tend to have higher complications in terms of diabetes and cardiovascular disease, asthma, et cetera. So they certainly would fall into the high-risk groups as well. So this is not obviously an easy problem to solve. We've known about it for a long time, but I'd like to make sure that in the collection of the data that we do know, that we do acknowledge that, and that we do know that underrepresented minorities, that the data does include them as well. I'm not as familiar with these particular studies that you've listed, but I think it's important to recognize that disparity.
Thank you very much for your comments.
We have Dr. Paradis, Dr. Smader, and then Dr. Gravenstein. Then I think we probably should move on to the next topic. So, Dr. Paradiso.
Peter Paradiso. I just want to make sure that people understand that a dose of the conjugate vaccine in adults over 65, you make a nice response and then it wanes quite rapidly. But it's efficacious for 3 or 4 years after that we've measured and probably beyond. A polysaccharide dose afterwards is not required for that efficacy. So the dose will renew that response post the conjugate vaccine, but it's not required for the efficacy. And so the really only reason for the polysaccharide vaccine is for the other 10 serotypes, not for the efficacy of the original 13. So the discussion of the interval and which gives you a higher booster after your initial conjugate vaccine is really not that important, because you don't need that booster for the efficacy against the 13 types. And so the interval should be really programmatic, as you discussed, and really about what works best for getting people vaccinated, rather than worrying about the efficacy against the 13 types, because I think you already have that covered.
Thank you. Dr. Smader from the American Geriatric Society.
Yeah, Ken Schmader, American Geriatric Society. Just for the record, the AGS strongly supports the one-year harmonization. There's been a lot of confusion amongst patients and providers of older adults, and this will reduce the confusion.
And along that line, just very greatly appreciate the comments from IDSA and from AGS, because that's the type of information we need in terms of the practicality and getting things actually out to patients out there. Dr. Gravenstein.
Thank you, Dr. Tempte. So to further to Dr. Harrison's points, those equivalents or graders are at day 30, and those differences dissipate. So Merck has a study underway to look at several different dosing intervals between P13 and P23, and we hope to have that data next year. But to Dr. Schuckett's point, yes, pneumococcal vaccine delivery spikes in the fall, coinciding with flu, but there is vaccine delivery all 12 months. And my training as a social scientist says we ought to make enable vaccination of adults when it's convenient to them, even if it's in February, March, April, May, June, July. And that is hindered by reimbursement constraints. And it is enabled by education. And when the patient comes to you, evaluate them and vaccinate them regardless of the clock. And the ethnic disparities are substantial and unacceptable. Thank you.
Dr. Reingold has a very, very short.
Well, the question is, if part of this has to do with reimbursement by CMS, is there any way to have that changed, the policy?
And Ms. Hans.
At this point, we don't feel that there's enough data. The decision was made based on the information that we have, and as we've heard throughout this session, there is not data supporting the intervals. And this original decision was made by CMS for a number of factors. One of them is the fact that you have the two inconsistent intervals defined, and Medicare does not track which pneumococcal vaccine is given first. Given the two intervals, the common point was a 12 months. In addition, as Dr. Schuchat has said, we have a very robust combined pneumococcal and flu vaccine campaign that happens once a year. And it seemed, if we were working with a 12-month period, it seemed logical to maintain that 12-month period and to continue to include the pneumococcal emphasis during the flu and pneumococcal campaign. If there are additional studies, we are certainly welcome. We'd be happy to look at them. We are happy to follow up with CDC and the ACIP. But at this point, without the information regarding the intervals, we feel that we have made the best decision that we can make at this time.
And Dr. Schuchat?
I would just like to publicly thank CMS for the extremely speedy regulation they made about the conjugate vaccine, and say that any kind of change is unlikely to go that fast. So I would keep that in mind if people are pushing that.
Speak. Okay, let's move along to the second part of this.
Okay.
Thank you.
Thank you very much. Now I will review the intervals for the sequence of PPSV23 followed by PCV13. This table summarizes the currently recommended intervals for the sequence of PPSV23 followed by PCV13 by different age and risk groups. To harmonize the recommendations, we can either change the recommended interval for children with underlying conditions from 8 weeks or longer to 1 year or longer, or change the recommended interval for adults from 1 year or longer to 8 weeks or longer. However, the recommendation of a year or longer interval for adults was made based on data from immunogenicity studies suggesting blunting of immune response to PCV13 with shorter intervals between PPSV23 and PCV. Therefore, we reviewed literature to determine whether evidence would allow change in the recommended interval in children with underlying conditions to harmonize with the interval recommended for the adult groups. The following were considered in harmonizing recommendations. First, the proportion of children who will potentially be affected by this recommendation is small. The following are the groups of children for whom this recommendation may be applicable. First, children who were 2 years or older who were indicated to receive PPSV23 before PCV7 became available in 2000. This would be the current cohort of 17 to 18-year-olds. Second is children with underlying conditions who, for whatever reasons, did not receive any PCV13 or received incomplete PCV13 series as infants and have already received a dose of PPSV23. Next is on programmatic issues and practical aspects. The change will make the recommended interval different from the current interval for PCV13 followed by PPSV23. On the other hand, the proposed changes would allow for harmonization of recommended intervals for this sequence across all age groups with underlying conditions. In addition, this change is likely to affect only a small number of children, as explained earlier. Therefore, the workgroup felt that these proposed changes would not likely pose substantial implementation challenges for the majority of providers. Next, we will review existing literature to see if evidence would support the change of the interval for the sequence of PPSV23 followed by PCV13 from 8 weeks or longer to 1 year or longer in children ages 2 through 18 years with underlying conditions. As stated earlier, ideally, we would like to review clinical efficacy data that are designed to compare different intervals for the sequence of our entrants. Since those were not available, we reviewed data from existing immunogenicity studies. Immunogenicity studies from adults have suggested that there may be a blunting of immune response to PCV when given after PPSV23, especially when the interval between the sequence was a year or less. Based on these data presented to the committee during previous meetings, for adults, 1 year or longer interval was recommended for PCV receipt post-PPSV23. We reviewed available studies in children comparing the response after the sequence of PPSV23 followed by PCV7 to the response after a single dose of PCV7 to assess whether PPSV23 receipt PCV7 administration, given the interval used, would result in decreased immune response. No studies using PCV13 was available for this comparison. We also reviewed one single-arm study among children with sickle cell disease who have received PPSV23 prior to study enrollment. No comparison group was available in this study, but the response post-PCV13 was evaluated, and the immune response post-PCV13 was assessed by time since PPSV23 receipt. Among the reviewed studies, there was no clear evidence of blunting of immune response when PPSV23 was given before PCV7 in comparison to the response after a single dose of PCV7. However, none of the studies had intervals that were less than 1 year. This slide summarizes results from a single-arm study that looked at children with sickle cell disease with a history of previous PPSV23 at least 6 months before enrollment. The median time since the receipt of PPSV23 was 2.9 years, with a range of 6 months to 11.8 years. The results showed that children were able to mount an immune response after administration of PCV13, and there was no correlation between time since PPSV23 and response to PCV13. In summary, none of the reviewed studies were designed to evaluate the optimal interval between PPSV23 and PCV13 in children with underlying conditions. From the reviewed studies, there was no evidence of blunting of immune response when PPSV23 was given before PCV7, compared to the response after a single dose of PCV7. However, all of these studies had an interval of at least 1 year between the two vaccines. Results from a single-arm study showed that there was no correlation between time since last PPSV23 and response to PCV13, but here again, the minimum interval was 6 months. In conclusion, we considered that changing the interval for the sequence of PPSV23 followed by PCV13 from at least 8 weeks to 1 year for children 2 to 18 years with underlying conditions would be appropriate for the following reasons. First, this would allow harmonization of the recommended intervals across all age groups with underlying conditions. Second, the proportion of children affected by this change would be small and would only apply to those who already have received a dose of PPSV23 and are eligible to receive PCV13. In addition, this interval would avoid potential blunting of immune response to PCV13. Excuse me. Although the blunting was not evident from the reviewed studies, none of the studies had an interval shorter than 6 months. This change, however, will make the recommended interval different from the recommended interval for the sequence of PCV13 followed by PPSV23 for the same group. This table summarizes the proposed change in the interval between PPSV23 followed by PCV13. If the committee approves the proposed changes in the intervals, this is how the new recommendations would look like. For those with underlying conditions aged 2 years and older, the recommended interval between the PCV13 followed by PPSV23 sequence would be at least 8 weeks. And for the PPSV23 followed by PCV13 sequence, the recommended interval would be at least 1 year across all age groups. For routine administration in adults who are 65 years and older, interval of 1 year or longer would be the new recommendation for either sequence. Thank you very much. I would like to answer any questions.
Okay, for this separate issue with the childhood, any discussion or questions? Yes, Dr. Veskis.
So the proposed changes would harmonize the pediatric ages with the adult ages, but it would actually do the opposite if you just look at children. So in some ways, I think it makes it harder for the pediatrician or the pediatric provider looking at this going, great, it doesn't matter whether it's 13 to 23 or 23 to 13, it's 8 weeks. So, I mean, as I see this, I think you're making it easier for the family practitioner who takes care of both, but as a pediatrician, I think this makes it harder for me, or more confusing for the pediatrician.
So we did discuss about that a little bit, but we were also thinking about the fact that you know, these are children with underlying conditions. You know, probably there'll be some specialists involved who might be seeing children or population that might cross the 18-year-old. They might be seeing like the more older population. So considering that, and also considering like the harmonization issue and like the immunogenicity studies, all that considered, yeah, we are making this proposal. But I would be happy to hear more opinions related to the practical aspects.
Dr. Schuchat, then Dr. Byington, then Dr. Boulanger.
Yeah, I just want to remind people that the conjugate vaccine for children has been used now for 15 years, and we have extremely high coverage. And so the actual number of children that are going to be in that right-hand column of having gotten a polysaccharide vaccine prior to getting that conjugate, I don't even know if they're double digits. Whereas the vast majority of the pediatric issue is that very high-risk child that should get a polysaccharide after a conjugate. So I think it's a little bit less that the practitioner is going to have a lot of confusion than that we do want that shorter interval because they're very high risk. Whereas there are 70% of people 65 and over who've already gotten a polysaccharide, and then every year a lot of people aging into the 65 cohort who will be now starting with the conjugate. And so I think that both boxes are really active for the practitioners seeing the over 65-year-olds. So I just want to remind people about the volume of questions that the pediatricians are seeing is really in the left column.
I'm going to follow up that comment just with, in primary care, the vast majority of kids that we see that this applies to are sickle cell. The kids who have the other high-risk conditions are being seen by our colleagues in peds, infectious disease clinics, and so on. But the kids who don't get these tend to be the sickle cell anemia children. Dr. Byington.
So I think the AAP has similar concerns to Dr. Vasquez about the confusion for the pediatric provider. And also, we'd like to actually see real numbers. The 17, 18-year-old cohort is a cohort that will age out, and it's very small, but these kids still exist, and they are at the highest risk, often coming from populations with disparities like sickle cell disease and HIV. And we're willing to delay the administration of the more effective vaccine from 8 weeks to a year for these individual children who also require by AAP guidance 2 vaccinations. So they need to get 2 vaccines in after the pneumococcal polysaccharide 23. So that is of concern to us, this delay.
Dr. Boulanger?
Yeah, so my question pertains to the complexity issue in using clinical decision support with immunization registries. At the Marshfield Clinic, we actually have built into our registry sort of clinical decision support. So this all gets programmed in to rules. And so even though the number of people, children impacted on the right side is quite low from a programming standpoint, it could be a substantial amount of work. So, and I don't know enough about that, but I guess one of the issues that was brought up was some of the complexity of programming this all into clinical decision support. And is this an issue here where really now it's still very important which vaccine was given first for programming this for children?
You have Dr. Moore and then Dr. Lair.
Kelly Moore with AIM. We do very much programmatically appreciate the simplicity. I was just asked by our own nurses to look at our protocols because they were getting so confused in our health departments trying to keep this straight. I think that from the program standpoint, for programming purposes, it will be helpful to highlight in the catch-up schedule that what the true minimum intervals are so that we don't, as Dr. Lett mentioned earlier, that we don't flag for repeats vaccines that were given according to acceptable minimum intervals. In case someone is still following the old way of doing things, we don't want to consider those doses invalid.
Dr. Lair.
I think from the practical point of view, when you're looking at a patient, you're looking at horizontally and not vertically. And so what we're actually doing is saying, I have a child who's 18 years old who's high risk, and I want the harmonization to be lateral, 8 weeks and 8 weeks. I'm not looking at it that they got the PPSV 23 first and I'm going down the column. So I would agree with the other two comments that it's much easier to harmonize from the pediatric standpoint than it is to harmonize from which vaccine was given first.
Other comment? Up the microphone, then Dr. Baker.
Mel Code from Merck Vaccines. I just want to comment that the kinds of comments that Dr. Moore alluded to from providers, that's the kind of feedback that we've been hearing from the marketplace. And given the difficulties in ensuring a second dose of vaccine for covering that 40% of IPD, that's not a trivial issue, getting coverage for that amount of disease. And so anything that simplifies the schedule and makes it easier to implement, I think, is a step forward.
At this point, can we move on to the recommendations? Oh, I'm sorry, Dr. Baker.
Quick. Bill has a comment too. Oh, you don't? No. Okay. We're sorry. We'll get our act together. So speaking for the IDSA and with respect to the AAP, because I'm an AAP member, the committee was very interested in the topic and is fully supportive of the proposed changes, realizing there are the issues mentioned.
Okay, I'd like to thank Dr. Kobayashi for this very thorough and detailed presentation. And I want to address one additional comment that was made about the horizontal harmonization versus vertical. So if we look at the adult age groups, adults 19 and older with immunocompromising conditions, so here the evidence was very clear when we made the recommendations. I think everyone was on board that a 1 year interval, the data was warranting that 1 year waiting interval because of immunogenicity studies that show that there may be some evidence of a blunting of an immune response when PCV is given closer to PPV. And so that was a decision. We did the grade and everyone agreed. As far as the children and this change, I understand the challenges that the pediatricians will have, but aside from the practical aspects, when we reviewed the immunogenicity data, there are no data with an 8-week interval. So we couldn't even assess whether the same concern that we saw with adults and potential blunting is evident in pediatric studies as well, because none of the studies that we reviewed utilized the 8-week interval, and the interval was a year or longer. So I think that's another thing to keep in mind, that evidence was also supporting this change. Lastly, what I wanted to do is for each of the groups that we're proposing the change, I wanted to highlight what the current recommendation language is and then present the proposed changes and highlight these proposed changes in the recommendation language. And then I'll pause again for any additional discussion or questions that the committee might have. So for the current recommendations for intervals between PCV13 followed by PPSV23 for adults 65 or older are as follows. This is the recommendation that was made in August of 2014. The dose of PPSV should be given 6 to 12 months after a dose of PCV13. If PPSV cannot be given during this time window, the dose of PPSV should be given during the next visit. The two vaccines should not be co-administered, and the minimum acceptable interval between PCV13 and PPSV23 is 8 weeks. And the proposed recommendation, the language is as follows. A dose of PPSV23 should be given at least a year following a dose of PCV13. The two vaccines should not be co-administered. If a dose of PPSV is given earlier than the recommended interval, the dose need not be repeated. And the latter statement, I think it addresses some of the comments, and I think Dr. Lett made this comment about the flexibility. And I think the work group, after reviewing the evidence, and you heard the discussion, and I think everyone agrees that the evidence is very limited. And so the work group felt that we should add enough flexibility to the language so that if a dose is given, it's still accepted. In addition, I think the comments were made about the programming and invalidation. I mean, this is some of the most common questions that we've been getting since we made this recommendation is the lower bound of the range that we provided, 6 to 12 months, as well as the minimum interval, was interpreted as if it's violated, that the dose should be repeated. And we discussed that on the work group, and again, I think everyone agreed that evidence is very limited for us to be able to provide any guidance on whether the dose should be repeated, invalidated, and repeated, and if so, when it should be repeated. And I think that on the work group, at least, there was an agreement that we should make that statement that we are not able to provide a guidance on repeating the doses, and essentially there is a flexibility allowed in this recommendation. So for the following group, the language is also very similar, so I'll finish that and then I'll pause for any additional questions. So the current recommendations for interval between PPSV23 followed by PCV13 for infants and young children, and this is with a history of complete PCV7 vaccination. These recommendations were published in a policy note in 2010. For children who have underlying medical conditions, a single supplement and PCV13 dose is recommended through 71 months of age. This includes children who have received PPSV previously. PCV13 should be administered at least 8 weeks after the most recent dose of PCV7 or PPSV23. And next is for children 6 through 18 years of age. And this was a policy note published in 2013. Children aged 6 through 18 years who have not received PCV13 and are at increased risk for IPD because of anatomic or functional asplenia, including sickle cell disease, HIV infection, CSF leaks, cochlear implants, or other immunocompromising conditions, and who previously received 1 or more doses of PPSV23 should be given a single PCV13 dose 8 weeks or later after the last PPSV23 dose, even if they have received PCV7 before. So the proposed guidance and the proposed language for children 2 to 18 years or old with underlying conditions is as follows. A dose of PCV13 should be given at least a year following a dose of PPSV23. The two vaccines should not be co-administered, and if a dose of PCV13 is given earlier than the recommended interval, the dose need not be repeated. So I'll stop here and ask if there are any questions about the language that we're proposing and the changes.
Any questions? Yeah, Dr. Hahn.
I just wanted to ask, there may be good reason, but to me the second sentence seems actually almost confusing. You've already said it should be given a year later, so why is there another sentence saying it shouldn't be co-administered? Because that first definition should rule that first sentence should rule that possibility out. And I'm sure that's been considered. I just wanted to ask why that sentence is in both those statements.
So this sentence was actually already existing in a current recommendation, and that was again in response to multiple questions that we receive, and actually multiple scenarios where provider says 2 vaccines were given together. And that it was not obviously clear, even based on previous recommendations, pediatric recommendations. So those scenarios have come up, and so we thought that we need to clarify that these vaccines should not be co-administered.
Dr. Rubin?
Yes, in terms of the pediatric, the proposed longer interval for if PCV13 is being given after the PP23, I think when we historically had the 8-week interval, that was before we had any appreciation of the blunting. And so I think that even though there's not data, you know, as was said, there is some data that there's not blunting if you use a 1 year or longer interval. I think that's considerable, because if we talk about the typical patient would be a sickle cell patient who's 3 or 4 years of age perhaps, has received the 23-valent vaccine. We're concerned about protecting them over the next 5-10 years, not so much worried about the next, and that to me overwhelms the concern about the next 10 months, which would be the interval. So just there may be more bang for the buck in terms of overall protection under the curve, so to speak. Of course, that's not data-based, but that's a reasonable concept based on the data in older individuals.
We have Dr. Frauhofer and Ms. Pellegrini.
Sandra Fryhofer, American College of Physicians. As a practitioner, I think the statement about not giving them at the same time is real important. It just sort of, it's such an important issue for the immunogenicity that I really think it should stay there.
Thank you. And Ms. Pellegrini?
I'm having trouble with this as a layperson, because what I'm reading, the first and the last sentence is saying is you should wait at least a year to give this vaccine, but really give it any time you want, because there's no minimum. And we say you don't have to repeat the dose, so it didn't matter if you waited a year or not, or any amount of time, as long as they weren't actually co-administered.
So if I can make a comment about that. So I think the chain of thought was, as we're laying out this recommendation language, is that in the main sentence, we would like to state what the preferred interval is. And then the following sentences are essentially like what should not happen and what should happen. So what shouldn't happen is the vaccine should not be given together. And then the last sentence is essentially to show that, you know, we are allowing that flexibility because evidence is weak. Whatever evidence we have, the preferred statement is in the main sentence.
I have Dr. Schuckett, Dr. Camp, Dr. Vasquez, Dr. Decker.
As an internist, it was surprising to me to learn about the incredible adherence and programmatic aspects of pediatric vaccination. So I say this in response to your layperson question, because I was kind of a layperson 10 years ago about this. There are a number of pediatric vaccines that, you know, don't work if given too young or at too short an interval or something. And the pediatric practice and the immunization registries and the programmatic people who work on that are very focused on valid doses and invalid doses and making sure that children are complete and up to date on valid doses. So the question of that second red sentence really speaks to that, oh, okay, that one doesn't count, I have to give another one, as opposed to the science here, meaning, you know, 8 weeks is probably going to work. It's not really that much of a problem. There's a lot of people now who had that 8-week interval, but going forward, you know, we'd like to give you the direction to program it in there at 1 year. So I think that it's not really like that it doesn't matter for this. People really are focused on what's valid, what isn't, because they're going to keep vaccinating you till you have all the valid doses you're supposed to get. And I don't think that's what the committee was trying to suggest was needed here.
Dr. Kemp?
I think the issues about harmonizing the adults and the pediatrics are really entirely separate almost. I wonder if we shouldn't separate them, but because this is not going to facilitate, it doesn't harmonize for the pediatric side, it harmonizes on the adult side. But I think what's compelling is what Dr. Rubin said, that this decision is being proposed not for that reason on the pediatric side, but because it may be beneficial and there's actually no data about the 8-week interval. So I guess I'd like to hear from more people on the Peds ID side about how strong a case that is, because I think this is a very different issue on the pediatric side.
Dr. Vasquez?
I also would love to hear that, if indeed it's based on the blunting. But if all I'm reading, if I'm a practitioner and all I'm reading is this statement, and I read that second red line, and my patient received PCV13 2 weeks after PPSV23, then that dose counts, according to what you're saying. So if that second red statement stays, then it needs to state if the interval between those two was at least 8 weeks. Is that correct or not?
So that would be like stating an 8-week minimum interval, which is what we had before. But the way that 8-week interval was interpreted before was if it's 7 weeks
Correct.
and 1 day, we invalidate
Right.
and we give it
Right.
again. And we have no way of giving guidance of how to do that and whether we need to do
But
that.
if we get rid of that and now all you read is this, and somebody had the 2 doses that were not co-administered, but they were given within 2, 3, 4 weeks of each other, then according to this, those 2, that counts.
Correct.
And there may be more blunting.
And on a case-by-case basis, this is the recommendation we've been given. We have no guidance to give on how to repeat, therefore do not repeat. And another thing is going back to what Dr. Shukert was saying, I mean, we've talked with a general recommendations group, with Immunization Services Division about that. You know, all the language that is in the pediatric recommendations about the minimum intervals applies to the same product. In other words, it's the minimum interval between the PCV doses, and you follow that and invalidate because we have some data that this is the optimal immune response. Whereas here, it's a little bit of a different issue. These are two different products, essentially 2 different vaccines.
I have one more question. Do we have to vote on both the proposed changes, or can they be split?
As an ACIP member, you could make a motion to split them. And actually, to be honest, the discussion so far, I think, if I can take the prerogative and just say from someone who's mainly an adult provider right now, the practicality of the adult thing trumps all the science. You know, my goal is to get my patients vaccinated. And if I can do that in a simple way that's paid for, everyone's happy. And on the other hand, I hear a lot of discussion here, especially from our pediatric ID colleagues, that more information would be nice. So I think it would be reasonable to split these 2 things. I would echo perhaps going forward with the adult today and bringing back the pediatric in October, if that's okay with the work group. I'm sorry, Nana. But
the only, I think, objection the work group would have to bringing it back in October is that it's unlikely, in fact, impossible, that we will have any additional data to present then.
Okay, I have Dr. Gamelli, Dr. Sawyer, Dr. Kimberlin, Dr. Baker, and
Dr. Zucker.
Okay.
So I don't know if this is going to answer Dr. Valkos's question, but to address Ms. Pellegrini's question, I do believe that it's really important for clarity when we or you put out these recommendations or these guidances, and if one person doesn't understand it or thinks it's confusing, then I think it makes sense to try to clarify it. So my suggestion, I hope it's helpful, is to suggest that perhaps in that second red line there, that the word inadvertently, to be very clear that this is not what's recommended as a practice, but if it happens to happen, then you don't have to repeat that dose.
Dr. Sir?
So I just want to remind people that this sequence of vaccines for children applies to a very small number of now mostly late adolescents. So I don't think we should get too hung up on this. That, coupled with the adult data which shows blunting and the lack of data in children, there's no biologic reason to think children might not also have blunting if we had the data. And the fact that you don't have to repeat the dose if you give it shorter than an interval, to me makes this, I think we should just go ahead and accept it as is.
Thank you, Mark. Dr. Kimberlin.
I guess from my standpoint, we're not seeing reports and have not seen reports in the literature that our current recommendations of greater than or equal to 8 weeks separation has resulted in failures. So while we don't have the data to suggest that the 8 weeks is correct, we don't have the data to suggest that there is blunting. There may be, based upon the adult data that also are limited, or there may not be. We don't have the clinical correlate that suggests we have a problem right now. And we're talking about changing something, albeit for very small numbers of children that are going to age out, most likely, if the rest of the schedule is being applied correctly, pretty soon. We're talking about taking a vote that would introduce disharmony for the pediatric side of the equation in what appears to me to be an effort to harmonize, across the columns rather than down. So I don't know, I don't think that it is going to impact major numbers of people, but I do think that some additional time to consider, while there may not be additional data, for the pediatricians to consider this more and discuss it more internally and come back with perhaps what may be a unified voice, whereas now we have a bit of disunity. That might be beneficial.
Dr. Bikini.
Well, I agree that pneumococcal recommendations is becoming more and more complicated over time. There's no question about it. But I think that, we've been working to educate pediatricians to provide the vaccines based on the recommendations that exist now. And this is a time-limited phenomenon because these patients are going to age out. So, and the new Red Book was just published and has the current recommendations in it, so why change them at the present time? I think we can work through this without changing the recommendations, without trying to change what pediatricians do now, and we won't harm anybody. So I'm not sure it makes sense to change what we're doing at the present time.
And up at the microphone, I'm going to, we'll take Dr. Baker, Dr. Middleman, microphone, and then I think in interest of time, we need to bring this to a close, so we'll go from there.
Yeah, thank you, Dr. Zucker, the New York City Immunization Program. And I just want to offer some programmatic and sort of practical considerations. So first, I'm someone who writes standing orders for pharmacists and for nurses, and I've had a tremendous problem trying to explain the pneumococcal recommendations as well. So I think it really is a huge problem, and perhaps everyone here doesn't appreciate, again, if you're not practicing or doing this, how hard it really is to explain it. The easiest thing and clearest message for me to give the practitioners in New York City is to say, for children, the interval between pneumococcal doses, vaccines is 8 weeks, and for adults, it's a year. That's easy, it's simple, I don't have to worry about, again, where the age break is, and it also is simpler for our registries. If you keep the pediatric recommendation the way it is, I don't have to reprogram my registry. Whereas if it is changed, then I will need to do that. We haven't actually programmed all the pneumococcal adult recommendations because we've had so much difficulty actually doing the programming. So if we have a very clear 1-year interval, I'll know when to say a dose is due. Based on the conversation, I'll take out any minimal interval and I'll accept any dose that's given after the other dose. So that's really the simplest approach. And just the last point, the comment about 2 vaccines should not be co-administered, and the following sentence is really confusing because CDC also says that if you do co-administer it, you don't need to repeat the dose. So, when is given earlier? Is it 1 day after the previous dose? But in fact, if it's 5 minutes after 1 dose, it's still accepted. So I think that we need some clarity on that as well. Thank you.
Thank you very much. Dr. Baker.
My comment has just been made. I think there's a problem with the second and third sentences.
And Dr. Middleman?
Hi, Amy Middleman from SAM. I just want to, this is sort of not my bailiwick, but I do want to mention that some older teens do have issues in terms of being eligible for VFC versus not, and if you delay for a year, there may be some that can get the first, if it's a year interval, then some will miss out on being able to be covered by BFC.
So I'm going to turn this back to the ACIP members, and the question is whether or not we want to proceed taking on both the adults and children or separate out the adult and Dr. Bologna.
Can I make a motion to separate them?
You may. Dr. Vasquez.
I second that motion.
Just wanted to clarify that, okay? So we have a motion and a second to consider this recommendation at this point in time, make sure I have this right, that the adult recommendation as it stands, we will consider, but we're also asking the work group to communicate with our pediatric IID colleagues and try and get unanimity and bring that back to the October meeting. So that's the motion, which is not a recommendation, but I think for something like this, we can just have a quick show of hands. Are we, Ann?
No, I was just going to say that listening to the conversation, it seems like the motion people are talking about is really to have a motion about the adult. And yes. I just wanted to make a comment clarifying about the status of the children. So I think basically the working group put on the table a proposal for changing the pediatric issue. I think the pediatric issue at Bay is a catch-up thing, not a routine kind of recommendation. As people were saying, it's like an age out of interim transition guidance thing. And so if you decide not to vote on this proposed change to that catch-up, I don't think anyone's ever obligated to bring it back for a future vote. It could be that one wants to, but I don't think it's obligating people to. I think the driving feature for the working group was the adult new recommendation that's not a catch-up, it's a new vaccine for adults, and that being incredibly confusing. So I just want to hone in on, the pediatric issue as something that could come back but might not even need to.
Thank you for that clarification, and we can leave it to the wisdom of the pneumococcal work group. Over my years here, one of my favorite movies is The Princess Bride, and the advice here is never get into a land war in Asia. And the advice to Nana coming in is always schedule more time for any pneumococcal discussion, because this is always the case. That being said, I believe the recommendation then, is there any change in this language that, so we have a motion, a second, discussion on the language here. Can you go back a slide?
We're talking about adults,
yeah.
right?
Yeah, we're just, so we have a motion, Dr. Bologna, to just, is a motion to adopt the adult?
Yeah, the motion was to just consider them separately.
Okay.
Not considering specific wording changes to the adult.
Okay. Would you like to revise your recommendation or your motion simply that we adopt the adult and leave standing the pediatric?
Yes, I would like to state it as such.
And Dr. Vasquez, would you second that?
Yes.
Thank you. Further discussion? Hearing none, Dr. Camp was out called. Would you like to start? And we can go to your right. And the language as it stands here.
Without the inadvertent that was suggested, we're not. So as it stands.
The adult only.
Yeah. Campus out called, yes.
Reingold, yes.
Rubin, yes.
Tempte, yes.
Bennett, yes.
Romero, yes.
Riley, yes.
Harriman, yes.
Harrison, yes.
Pellegrini, yes.
Karen, yes.
Bologna, yes.
Camp, yes.
Bocchini, yes.
Vasquez, yes.
And the motion is passed 15-4-0 against. Thank you very much. And we'll leave it to the work group to see whether or not you want to bring anything back or for a number of reasons, especially a very small group which is rapidly aging out, whether this needs to actually be considered. Thank you. And I'm going to take the prerogative, if we could move forward, Art, just to go ahead with the combination vaccine. I'll make a quick mention here for people who are paying attention to the schedule. There's no vaccine supply update, so we have that time for catch-up. And I believe we only have one public comment that we'll take during the pertussis section. And also, we'll plan to take a break after Dr. Reingold.
Okay, well, good morning, everyone. Let me add my thanks to John for his excellent chairmanship over the least time I've been on the committee. This is actually, I can help get us a little bit back on schedule. This should be a very quick presentation. I think everyone knows that ACIP has a number of working groups. Some of them are permanent working groups because of the need, but others are really only temporary. And this is basically a brief announcement to say that we have formed a new working group whose existence should be relatively brief. It may be able to go away after the October meeting. So to try and make this quick, in essence, I think everyone knows that we all benefit from combination vaccines because these combinations can provide equivalent component vaccines into single products, reduce the number of injections, reduce concern among parents regarding the number of injections, and presumably help with coverage and timeliness. So the new working group, the terms of reference for this combination vaccine working group is to review published and unpublished data related to the safety and immunogenicity of two current combination vaccines. Dr. Sun a few minutes ago mentioned the Quadricell DTaP IPV vaccine for children 4 to 6 years of age. And the second combination vaccine is an investigational hexavalent vaccine that actually combines products from two manufacturers. So it's DTaP plus IPV plus Hib and hepatitis B in a 3-dose series for children at 2, 4, and 6 months of age. So I think people on the committee are already relatively familiar with the Quadricell vaccine. This is a diphtheria and tetanus toxoids and acellular pertussis, together with an activated polio vaccine. It's intended as a second DTaP IPV vaccine for children 4 through 6 years of age, a 5th dose in the DTaP series, and 4th or 5th dose in the IPV series in kids who've received 4 doses of Pentacell or Daptocell. This was approved, as Dr. Sun said, by the FDA in March of this year. There has been a pre-licensure pivotal clinical trial, a multi-center randomized controlled phase 3 trial, and a variety of types of data have been and are being collected. So we will be bringing that, we'll be reviewing this committee will be reviewing the data about the Quadricell vaccine and bringing them to the ACIP at the October meeting. And then in addition, there's this investigational hexavalent vaccine. It's a combined product of vaccines made by Sanofi, Pasteur, and Merck. It's intended as a 3-dose series, and licensure is expected in the fall of 2015. And basically over the course of the summer, Merck and Sanofi will present information to the working group by telephone conference call. The working group will review the safety and immunogenicity data, and the plan is to bring this hexavalent vaccine to the group for a vote and for a VFC vote at the October meeting, and then to put a notice in the MMWR by the end of the year. So just to say that I've been asked to chair this group. Marietta, I hope, will stay on during the summer, although the fact she'll be leaving ACIP when new members join, but that she will stay on the committee. And then we obviously have the typical expert support from Jennifer Liang and Gina Mutri at CDC, a variety of liaisons. So and a number of other working group subject matter experts from CDC representing the various antigens that are in the vaccine and the very important aspect of vaccine safety. So that really is all I have to say about this work. I'd be happy to take questions. Dr. Baker looks confused. I don't know if she has a question, but Carol, did you have a question? You looked confused.
Dr. Moutry?
Yes, Gina Moutry. I just wanted to correct one statement. The work group already reviewed the safety and immunogenicity of Quadracel during our May conference call. It will be the hexavalent investigational vaccine that will be presented to the ACIP in October. But Quadracel has already been reviewed by the work group, and there were no concerns on the data. And there's also no VFC vote that's needed for that because those vaccines are already approved according to the VFC regulations.
Thank you. Yes, Dr. Baker.
That confused face is I was looking for an AAP member on the work group and I found it, so I'm not confused.
Thank you. Other questions, discussion on the combination vaccine work group? Hearing none, why don't we take a 10-minute break, come back here promptly at 10:15.